live. So, good evening, everyone in the U.S. Good afternoon, Australia people. We'll wait a few minutes to have people join, and then we'll get started today.
Well, while Angela's saying we're going to wait to get started, I'm going to introduce myself. I'm Terry Arnold, and I'm the founder of the IBC Network.
There's nobody live yet, so they're not seeing us.
Well,
But no, live. There's nobody watching.
We're live. Nobody's watching. They may not watch, but they'll see us being silly when they tune in later.
Well, maybe you can crop out the first bit.
I know we can crop it out. Roll back that tape. Are we going to be the Three Stooges? Did you know the first time I ever did a live radio show was years ago, and the first thing I said on air was "Pick your poison."
Oh my!
Yeah, it was great. Okay, we ready?
Currently, I'm the only viewer.
You know, we may not have a lot of viewers from the beginning. I'm not worried about that. I'm going to watch it later. So we are live here from Houston, Texas. So welcome to all of our U.S. listeners who are seeing us now on a Thursday night about 9 o'clock. And for all the people who are joining us from Australia, it's about noon there. I know you've got 3 time zones, so work with me. I think you kind of get the picture that the middle of the country is noon. And like I said, I'm Terry Arnold. I'm with the IBC Network Foundation, and I have with me a couple of people that I really want you to know. You may know Angela Alexander because she does a lot of things live with MD Anderson and Dr. Wayno, and she's here to help us and going to give a few stats, and then she's going to step away and maybe monitor for any kind of questions. And I have with me someone.
Claire.
Hey, Claire, I'm going to wave at you.
Hi, Claire.
We've got someone I want you to meet. I want you to meet Bedrich. He's got his very official coat on here.
Thank you.
And Bedrich Eckhardt, and he is a researcher at MD Anderson. If you notice from his accent, say hi.
Hello, Facebook.
He is from Australia, and he is a researcher here in Houston, Texas. He's going back to his homeland soon. He wants to take his research with him, his passion for IBC with him, and we want to kind of give you guys a little bit of a 411 on some things we want to see happen, and we hope that you'll want to join in on us. So I'm not going to wait for the audience to grow. I know this is sort of a new thing, and I know you can archive it, see it later. So we've got to get started. You want to say hey to your wife? She's watching at home.
Hello, everyone back in Australia. Midday Eastern time.
Yes.
Which everyone's on the east largely, and there's a few people on the west, and a lot of people in Tasmania, which are down south, which is where I'm from.
Really?
So,
I didn't know how I knew that.
Yes.
Yeah, something new.
Yep, I'm the island off the island.
How about that? We've got also a lot of people from New Zealand who are coming in, and you know, it's really interesting to me that to be sitting here today, because I think you have a little bit of history that you might not know. When I got diagnosed with inflammatory breast cancer 11 years ago, I met a woman named Ginny Williams, and Ginny was from New Zealand. And she had a blog that was very powerful, and she titled it "Get Out Gertrude," and you can still find it. Ginny was the one who encouraged me to start a support group for IBC, and she said, help me do this. There were 7 of us from around the world that put together this group. In the U.S. group, we now have over 700 women, and we've got multiple groups in multiple countries and multiple languages. But it was Ginny who was like, we have to do this, and she said, it needs to be you to help, because we need a
Can you
Houston.
speak up a little?
Yes, I can speak up.
They're saying the volume is too low.
I don't know. Is it better now? I'll give you a minute to say yes or no. Can you hear me? I feel like that commercial. Now we're being quiet. But Ginny Williams is the one that encouraged me to put together the support group. And when I did that, then years later, did the charity that now you're focusing on today. But Ginny unfortunately passed away, but her legacy has been strong. And so I wanted to bring that in because it was very exciting to me to have an opportunity to do something in Australia, possibly New Zealand, because of that early day connection and what she meant to me. And I know her family is very interested in what we're doing too, so I wanted y'all to know. So I want you to tell them about what we want to focus on our first point here, about the rareness, the disconnect, and the things we want to talk about.
Okay. So we've been talking for loud. Loud. So a little bit about me first.
Someone else has said the volume's good now.
Okay, good. Yay.
So just before we touch on that, I just thought I'd give a background on myself as well. So my name's Bedrich, obviously. I did my research at University of Tasmania. Then I studied very aggressive breast cancers in the University of Melbourne through the Peter MacCallum Cancer Centre. And I got interested in inflammatory breast cancer specifically because it was a largely known but not well described entity back in 2008, 2009 when I went to a conference in America, and I got very interested in the topic. So I flew over to America, and I've been studying here for the last 9 years on inflammatory breast cancer, and we've found lots of cool new research methods that we would like to implement back in Australia. But the problem being is, our first point is inflammatory breast cancer is still largely uncharacterized in Australia. One of the biggest problems was some of the early papers, early studies or demographics was suggesting that inflammatory breast cancer is so rare in Australia that it's an anomaly.
Now, when you say uncharacteristic, what do you mean by that?
Uncharacterized.
Uncharacterized.
So, I mean, it's not described. What is IBC? How do I know I have it?
Mm-hmm.
So, what we now know after about a decade of research is it's an unlocalized spread cancer which can change the shape of the breast. It's very aggressive, it's invasive, and it has it does not respond well to therapies generally.
And it doesn't have early forms of detection.
Correct.
Skin presentation.
Correct.
All the things we don't think of as cancer.
Correct. So yeah, no lumps, still cancer is the catchphrase with that, and it's very, very true. So because of these uncharacterized population, it's very hard to work out how many people actually have it.
And by the way, we do have a male survivor.
Who just commented.
He just commented.
Hi, being a man in Australia with IBC, that's the definition of rare.
You know, it's interesting you said that, Rod. Hi, because I was just going to bring it up. Oh, you're over there. I'm looking at the wrong place. I was just going to bring that up because we do have you in Australia who's been a tremendous voice about male breast cancer. And for you to be the rare in the rare is interesting because I was reading some stats the other day that said that about 5,000 men in the U.S. get breast cancer a year. I was also reading some stats that about 5,000 women in the U.S. get inflammatory. So we are kind of like, I don't know, I think makes you a little overachiever or what. But anyway, I'm glad you're commenting. I'm glad you're a big voice, and I'm looking forward to meeting you when you come to the U.S. I know you're coming for Project Lead. I don't think I'm going to be at that, but, you know, we'll get a chance to keep going. And I think you will be particularly interested in what Bedrich wants to do because you've been such a champion. So keep talking about that. But go ahead. You got this uncharacteristic disease. It has no defined definitions, poor protocol.
Yeah, so therefore clinicians will see a patient with this disease but may not know it's inflammatory breast cancer. One of the problems with the disease also is the fact that it's misdiagnosed. Sometimes it's considered not even cancerous. And
Five doctors misdiagnosed me over a period of 4 months. It's an absolute miracle I wasn't already stage 4 at my diagnosis.
Right. So and then you have all these treatments and it keeps getting worse. So the point we're saying here is that because it's misdiagnosed, we don't actually know the number of people that have inflammatory breast cancer in Australia.
Now the government says there's about 15 cases a year from a paper I saw that was dated about 10 years ago. And so we know clearly there has to be more than 15 cases a year because just from what we reflect in our support group is a significant number. We can't have captured every single one of them.
Correct.
And there's no coding number to trace them to know. So all it's going to show is they died of breast cancer.
Correct. When they do the big population stats and they go through the diagnoses, if there's not a category to say this is inflammatory, then they can't report on it accurately. So the report of 15 inflammatory breast cancers in 1 year in Australia is very low, considering 13,000 Australians are diagnosed with breast cancer annually. So that's looking at 1 in 1,000. Right?
And the U.S. statistics range from anywhere from 2 to 6, depending on who you're talking about.
Percent of total, and we have about 240,000 a year here.
And so it doesn't make sense for the numbers to be so low there, because there's nothing unique about this we know of culturally or.
Perhaps risk factors may be different.
Yeah, the risk factors,
obesity,
African American,
exposure to viruses.
Right, but even like in places like Japan, that doesn't have some of the risk factors, their breast cancer's on the rise significantly. And so they used to be 1 in 15, now they're 1 in 6, 1 in 8.
Right.
Very much along the lines of the American standard.
And I think that also comes in with detection as well. But this is not IBC we're talking about, though. This is general breast cancer. But with inflammatory breast cancer, that is such a low number. It's would consider the fact that maybe Australians are just resistant to it, but that is not the case.
I wish they were.
Right, because then we'd study them.
Yeah.
I mean, I'm not for Australians being lab monkeys or anything like that.
Oh, but I'd love to find some.
But if it could help the greater good, of course.
Yeah. So get back to what you want to bring. The rare disconnect.
So yeah, the rare disconnect of the fact that maybe it's a rare disease, a very rare disease in Australia, was recently debunked by a paper a year ago, which showed at one hospital, the Royal Perth Hospital, they found in 10 years that one hospital itself had 70 cases.
In 1 year?
No, in 10 years.
In 10 years.
So that is one hospital out of
but
many
that's seven.
hospitals.
But that's 7 cases. They couldn't have captured half the country.
They estimated it was 1.9% from their case study.
Right.
So now
And
that is
there's a comment from Claire that her surgeon told her that the surgeon saw 4 cases in Mildura over 20 years.
in Mildura. Okay, so that's a small remote township, but it's a country centre as well. A lot of
Right.
people come there to be diagnosed. Now the tough thing there is they may not be equipped with the right resources to either diagnose or treat. So they would have to probably move the patient to a larger city centre to get the adequate care that they would need.
Can be difficult in such a vast country.
Very, very difficult, yes.
Now, I want to say something while we're talking about the early detection and all that. A mammogram, typically, because I know probably the audience that's watching this is interested in IBC, but if your friends are watching it or whatever, mammogram doesn't typically find it. It's webby and diffuse like cotton candy, so it shoots through. An ultrasound tends to have the same problem because they're looking for a mass. What tends to sometimes happen on an ultrasound, you'll see the skin thickening if the breast has already begun to get that peeled orange look to it, that it might pick up that skin thickening, but the technicians aren't typically trained to look for that. The other thing is too, think about it, when you go get a mammogram and an ultrasound, they put you in a dark room and nobody actually really looks at you. Personally, I think we should flip on the lights. It's okay, we can see each other, because sometimes eyes on is what's going to make you go, wait, that's not normal, because often your doctor doesn't see you, they just order a mammogram, and you get, and no one ever actually gets their eyes on you. And so then what happens is if you get a negative for your mammogram, you get a negative for your ultrasound, you can get a punch biopsy or biopsy, but here's the problem. Biopsies have a 25% false negative rate, and that is a stat out of Dana-Farber's recent research. So that's a pretty high false negative rate. Now, you don't want to keep chasing and looking for something that may not be there. But if you've got these clinical presentations of IBC and you've got a false mammogram, a negative mammogram, a negative ultrasound, a negative biopsy, the next step is an MRI. MRI will not miss it, but a lot of countries don't do MRIs or they're hard to get. Canada is a very sophisticated country. They do CT scan, they don't do MRIs. So there's a delay. So that clinical presentation can lend a proper diagnosis. But that's one of the things we have a disconnect on getting a code, because that's not that's a subjective standard that people can't agree on. Always, how much do you have to have the rash? How much the breast has been consumed by the rash, or whatever. So it's important that we get the standard of care really tight, and we'll minimize misdiagnosis and have women get the treatment earlier. Or stage 3 is the first you can find it. The difference of survival of a stage 3 and a stage 4 is pretty significant. So we would like to, save lives by getting earlier diagnosis and getting proper treatment. And so that's where he's getting back to you, what you want to bring to your country.
Right. So coming from the fact that Australia probably does have a proportion of IBC patients that are on a par with an international level, the problem being is it's only one institute. So we need to really confirm this in other institutes across Australia to see whether or not this is the case, and also to garner more clinical material, things such as pieces of the tumour from the patient, blood samples.
So you want to start a biobank?
Patient characteristics, yeah.
Is there a biobank now?
No, there is not.
And you want to create something multi-institutional?
Yes, multi-institutes, multi-centres, as I was saying. So we can actually get the numbers of patients logged, characterized, so we can actually perform solid clinical translational research. Because even with a small cohort from Royal Perth Hospital, which is a great starting point, it's only about 50 samples. It's not enough to really characterize what are the risk factors, because as soon as you start looking at various aspects, your patient number needs to be bigger. So 50 is low. We want to look at something about 400, 500. We want a 10 times increase. It requires more than one institute, and will require more than one state in Australia.
Okay.
So
I'm sitting here watching Angela nod. I don't want to put you on the spot, but Angela is a researcher as well.
True.
And so she can speak from this front experience. I know you want to talk more about numbers and stats possibly, but still, I'm watching her nod, and so it's just making me feel better about what you're saying, so the audience can understand. I think most of us don't have a clue what it takes to do research. We think you just buy a cell line and you get started.
Right, and that's not the case.
No.
Because what I've seen from my experiences here at MD Anderson is it takes a village to push a project. You know, you need people from different areas that need to come together for one focused reason. And amazingly, MD Anderson has done that, and they've over the years have been able to accrue such a cohort of patients that they can
We have
do.
about 600 on our
Yeah.
IBC registry over 10 years.
It's fantastic. I mean, it's the world's biggest resource as far as I'm aware. And finally, we're able to do some research here which we can actually pinpoint reasons why targeted therapies for the cancer and actually put them into the clinic as early stage trials. So ideally, we need to lift Australia from a nice root story to a level where we can be competitive internationally, and not competitive, obviously, collaborative internationally.
Well, you want to offer your best. I think
Correct.
that's what you mean
Correct.
by competitive. You want to offer your best.
Right, exactly.
And you know what I would like to see is that when they have the conference in San Antonio every year, it's the largest breast cancer conference in the world. It's in San Antonio, Texas, the first week of December. Is that doctors come from all over the world, researchers, clinicians, radiologists, nurse practitioners, everybody that's interested in breast cancer comes. And we're trying to make that be more of a meeting hub where we can talk about IBC and how we can network. Because everyone knows someone, just like I know him, and I know he's going back to his home, and I want to talk about this unique opportunity we have to take this man who cares very much about IBC and bring that to his homeland, bring that bench research, bring that cooperation, bring the things he's seen here and how much you can bring from here
Right.
there, I'd like you to talk about, and also explain to people how long it takes to go from bench to true application of patients.
Right.
Because I was shocked.
It
It
takes
is
a
so
long
slow.
time.
It's like
Yeah.
10 years.
It can, and longer sometimes. Depends on the target, how good the drugs are to it. Can you get the right number of patients to test it? Is it the right test? There's lots of, at every point in turn of moving a finding from basic research to an actual clinical application is just beset with drawbacks and wrong turns. But each time these happen, they're an environment that helps you make it the next step better. So there's forward progress, but it's not linear. So,
Right. Well, and I feel like I'm standing on the shoulder of giants because I benefited from something that was done before for me. And so my deal is I want to pay it forward and make it better for the next person. Hopefully one day we don't need to do this anymore. And I really want to put out a call to action that I would like people that are interested in seeing research come to Australia to be part of this, because the IBC Network has been funding heavily research in the U.S. We have a sister charity now in the U.K. that's funding. We hope to be starting something in Canada soon. And what we hope to do in Australia is not go in and say, well, we're going to start a charity and fund. Maybe we'll cooperate with an existing charity that wants to grant but doesn't have the money because there's not been the interest. Or maybe we can cooperate with a hospital that he's identified that is interested, and we can funnel some things that way. We have to start this conversation to make it happen. And so I'm disappointed you're leaving because I'm really fond of you. But I'm also very glad you're going back because I think you're going to bring some great things.
right.
There.
And I'm really passionate on bringing what I've learned back home. And I am also going to miss Texas. I did not think I'd be here 9 years. The initial plan was 3. But
Yeah, but
the
Texas,
sunshine is so nice.
Texas is hard to get away from.
It is.
I'm a native, so I can't help it. I've never gotten away. Okay, so we've talked about the awareness. We talked
Right.
about some of what we want to bring
Right.
to the country. What would be the next step in your mind that you want to share with our audience?
So the next step, I guess, is getting the components and the ducks in a row, so to speak. Reaching out to those people that are interested in doing this research at multiple institutes. Getting them on board.
You've been talking with people. You've been visiting.
Right. So yeah, we have I have one of the persons that was on the paper that described IBC in Perth is a collaborator of mine, and we're talking about trying to get a project developed there where we can utilize that already characterized small cohort of IBC samples to give us the necessary preliminary data to help expand that. And for that, we'll be seeking government funds, foundation resources, and institutional support. But again, we'll need to move it from the basic also with clinical aspects. We'll need to start getting people from medical oncologists, pathologists on board, so we can try and develop a small center, but we have to start off basic. We need to get the ground up and running from a solid platform. And my aim is to do it through basic translational research.
Well, and this is a great place for patient advocacy to come into play, because when patients ask for stuff, it can make things happen, and patients are getting a bigger voice at the table all the time. And also, there's just simple things that you could do, like when you're going to your hospital, when they do, I don't know if they have such a big pink push in Australia as they do in the U.S. in October, but I think it's still there, is, you know, can there be some IBC education in there? Can there be, you know, I'm always chastising people, and they've got the little forms out that you can feel to know what a breast feels like with a lump in it, and I said, where's the male version?
Right.
Because the male version is very different. It feels very different. We need to ask for that, and it makes it happen. And then, you know, if you ask for some education and you can start showing you're interested, hospitals want to have more money coming through them. And if we let them know we've got something we want to get funded and we care about, they're going to start listening to you. And then people like you can do the research we need to get done.
Right. Exactly, yeah. And we've been in talks with other research groups within Australia. In Melbourne at the Olivia Newton-John Cancer Research, one of the leaders there, Matthias Ernst, he's got a project that's looking at inflammatory breast cancers. Why are they inflammatory? How does that support the cancer cells to grow? And trying to develop new models to investigate whether or not other drugs could be used to stop this effect. So one of the greatest resources that we have here at MD Anderson, which we would like to bring back home, is expanding those models. We just don't have enough. One cell line, one tumor model is not all cancers. There's so many different types of breast cancer. How could one model could ever be complete? And then for inflammatory breast cancer, we only have a handful of those. So there's a big requirement to develop these, get more of them. And the only way we can do that is through integration with the clinic, with pathologists, and the basic researcher, where we can get patient, hopefully they can go through their course of treatment in the right fashion, but at the same time pair that with basic research so we can try and find reasons why that cancer is doing what it's doing.
So where would the center be based?
Right, so if I was to, when I return, I am returning, it's
You're
October.
leaving in October?
Yes, hopefully to a position at the Olivia Newton-John, which is where this research for translational breast cancer and inflammatory breast cancer is happening in Australia. And through that we'll connect through other hospitals that are in Victoria, so Melbourne's in Victoria, but also to try and connect with those in Sydney, New South Wales, also in Queensland, and try and get those bigger institutes to come together to develop a centre of shared resources.
Well, I don't know if there's any more questions. We'll keep popping up. And if you've got a question and you didn't get to answer it today because you're watching this with the archive, that's okay. Shoot us a message and we'll get together and we'll chat about it. So when you get back home, hopefully you can get started there, but you're going to need the funding and you're going to need the resources to do it.
Right.
What kind of international support do you think you can get when you're cooperative?
Right, so the collaborations we have here at MD Anderson through Naoto Ueno, who's a major leader in inflammatory breast cancer research here in the States. He's very collaborative. We have collaborations in Europe, Belgium, England, and everyone, there's this nice tight-knit community of researchers that do want to make advances in inflammatory breast cancer. And they've been very supportive for helping us develop what we could do in Australia. But we do need the resources, cell lines, tumours from animal tumours, so we can describe the effect in vivo, as we call it, in animals, as a prelude to trying it in patients. But we do need to get those established in Australia because there's not enough of them. So if we don't have those, we can't even start. So we can either start at grassroots and it'll be a slow progress, or we can do it collaboratively where we can start already at a level which we can push further faster.
See, I like a little combination of both. I want to see that collaboration, but I want to see the grassroots support because you need the people feeding that interest. I want to see that higher institutional deal, but I want to see the grassroots of the patients talking about, hey, I want my sample sent to where this is, because even though I've had my biopsy someplace, my biopsy could be valuable as part of that registry. And how do I get my biopsy to that registry? Or if you give a donation to a charity, say, by the way, how much of this could possibly go to inflammatory breast cancer research? I care about late-stage cancer. This is a late-stage cancer. I want to see some funding. So there's ways that patients can drive this that are not too demanding of them. And we can have that impact. And I think we've had that with what we've done. and I wanted to see how's the best way to go forward. Some people ask me, are you going to go there and start a charity? I would really like to try to identify people that want to run front on that, just like we do in the UK, and then we can be of support. Or identify someone who's established and wants to work with us to bring more funding into research for inflammatory. Because we know this is a really nasty disease, and without research, we're not going to be able to get where we need to be.
Correct.
You know?
And you're right. So the projects that we're looking at will be using what we call archives, with archive samples, but we do want to get those patients that are newly diagnosed so we can bring them in to help bolster up our research group, research materials.
You know, I realize there's something I haven't asked you, so I'm going to put you on the spot.
Oh, God.
I know, he's like, oh God, I've never done a Facebook Live, and she's going to ask me something.
Facebook newbie.
Is there a simple little skinny that you can give on what you're studying right now? It's, I don't want you to tell too much detail,
Sure.
but just, I know I love hearing scientists talk about their research.
Okay.
So is there something that you're saying now that you could talk about?
We recently published a paper, I think about a month ago, where we're trying to prove that we can culture tumours from patients outside of the patient. Now we have this really cool method where we get the patient's tumour sample, and we smash it all up, and then we put these iron nanoparticles on these tumours, and it makes them magnetized. You put it next to a magnet, and they form together as a mass. And in a couple of days' time, they're actually growing as what we call an organoid. So it's a growing mass of tumour that is living outside of a human, just in a dish with nutrients. And we've shown that is very reflective of what the patient's tumour is. So the cool thing we can now do with this living organoid is do screens, such as we can throw on a combinatorial drug library and screen which one out of thousands of drugs can kill these organoid masses, and potentially those drugs could be used then on the patient. Now,
see, stuff like that gets me so excited.
Right, get me excited.
People talk about, like in a Hollywood star, I get crushes on researchers because I think this stuff is exciting.
Yeah, it's really cool. So we have this great application, and we're hoping to move that forward. So we demonstrated that works on patient tumours grown in an animal, then in this culture system. We now need to do the direct patient to culture system, because the assay could be performed in less than a month. So if you were able to get the patient sample and identify a drug compound that would actually destroy this organoid, it may have an effect on the patient's tumour and the patient's tumour and hopefully their survivability, because it'd be amazing that you could do such a quick test and then have it's like tailored therapy all in a space of a short time. Meanwhile, obviously the patient would be going through their routine therapies, which is chemo and all that sort of stuff.
Yeah, like when you're doing stuff like this, see, one of the things I think is interesting is I've had researchers contact me and say, if I only had $50,000, I could do this. And then I would have enough discovery science to go forward, to go to the government, to ask for that really significant grant. But what stymies them is the ability to have that first little bit of money, that discovery science money, and that's someplace where the IBC network can be impactful. And we are giving out bigger grants. We hope to one day be more than just that lower level, but also I take a lot of pride in that lower level. Dr. Wendy Woodward often says we're a good investment because we give that discovery money. We have had several grants go to the government in the U.S. and get significant, and that's something that you're hoping to do with your research. Can you talk a little about how some of that works?
Sure. So, very true. Small grassroots funding just to at least get the idea fabricated and some results to prove that it's feasible. Having that allows you to apply for grants for funding through the government specifically, and that can really bolster up and take that project to the next level. But it would have never gotten there if it wasn't for those first early preliminary discoveries. So for the research that we were looking to do in Australia, we're looking to get these cohorts of patients with IBC in Australia and perform some molecular analyses on these tumour samples that we already have, but we don't have the funding to actually investigate them. And at the same time pair that with new samples from current patients and try to make new animal models with that, and also then do the genomic studies on their tissues. And having that is an amazing resource, because then we can actually say we have this established cohort of breast cancers in Australia, which will allow us to follow the patients and see what targets might be important, what drugs might affect the tumours the best, but it can't start at the moment, because at the moment all the samples are in blocks and put on a shelf somewhere. So we want to get those samples out and we want to activate them.
I don't blame you. I want to too.
Yeah, there we
Angela,
go.
you're smiling and nodding. Is there anything you want to add? She's like, don't put me on the spot.
No.
Did you see that? No. It was a serious no. Well, I guess we probably have to wrap it up.
Okay,
You see, if there's anything you want else to cover.
No, I think that's great. I mean, it's been fantastic to talk.
Well, see, you were so nervous. I'm a big call to action girl.
A big
One of
call
my-
to action,
I am
yes.
a big call to action girl. My deal is this: is tell somebody about what we're doing. You know, everybody knows somebody. Somebody might find this really interesting and be as interested in participating. And we've got patient samples sitting on shelves. That makes me crazy. I want those things going to use, not just be archived in a block of paraffin somewhere. You know, I want to use that to save somebody's life. If you're a patient and you're going through treatment, God bless you. I don't want you to feel the need to have to become an activist, because sometimes all you can do that day is take care of yourself and get out of bed, and, you know, more power to you. But if you're somebody, you know, who wants to be involved, write a few letters, talk to somebody, do that. If you're somebody who wants to get part of what I think is going to be a really groundbreaking science, I think IBC's time has come. This disease has been written about since the 1800s. This is not anything new. But I think as we evolve as science, we can do more about it. And so I'd like to be have you be encouraged, be part of this movement we want to do to make something happen in Australia that's going to save lives and spill over into New Zealand, and it's going to make everything there better. Better science, better standard of care, better education, and people can live long and happy lives. And so when you say, how can I help? Everyone can do something. So if you want to give us a shout through the website, or through Facebook or whatever, or you want to talk to Bedrich directly, I can help you contact him, and we can see what we can do to make something happen that's going to be really good for your country.
Thank you so much.
That sound good?
Yeah, it sounds fantastic. And I mean, also, we want to activate those people that are seeing patients.
Yes.
I mean, we want to find those clinicians that are seeing their patients. Can we get them to come to the table, talk? I mean, everyone knows a little bit about inflammatory breast cancer, but it seems that the best therapy is what we call multimodality. I mean, you need your clinicians to talk to your radiologists, to your radiotherapists, to your med-oncs. I mean, we need everyone together, and it's not easy when people only see one side of that one patient's disease. So we need to get these people together so we can do better clinical therapy as well as studies.
Well, I'm really pleased. And I'm Terry Arnold. I'm with the IBC Network. I have Bedrich Eckhardt with me, who's going to. That's your network.
Bedrich Eckhardt.
I always add a letter to his name.
Yeah.
But I don't say it with the accent either, so you say it.
Yeah, so I probably, well, in Australia we call it Eckhardt. I'm sure it's probably pronounced different in Czech Republic.
Well, it's definitely pronounced different the way I say it.
Yeah.
And Angela Alexander's with us too, who's also a researcher at MD Anderson and helping us with this live Facebook. And so if you've got some questions, hope I hear from you, and thank you for listening.